Good evening, everyone, and welcome to the master class. Tonight, we'll be addressing poor bone quality and repair in the shoulder. Our sponsor tonight is Anika. The organizer is Orthopedics This Week. Please use the Q&A box for questions, and we'll address those at the end of the talk tonight. Tonight, we're joined by Dr. Wasik Ashraf. He's a board-certified, fellowship-trained orthopedic surgeon. He specializes in sports medicine and joint preservation, as well as cartilage restoration. His residency was in orthopedic surgery, which he completed at Northwell Hospital System. He then went on to perform a fellowship in sports medicine, which was done at the Houston Clinic in Columbus, Georgia. Currently, he practices in Orange County, New York. We're also joined by Greg DeConcilius. He's a physician's assistant that began his career in 1999 at the New England Baptist Hospital. And then in 2004, he decided to leave the hospital and start Boston Outpatient Surgical Suites at Waltham, Massachusetts. Greg is the president of the Massachusetts Academy of Ambulatory Surgery Centers and sits on the National State Affairs Committee. I am Christopher Baker. I'm an orthopedic surgeon, and I practice sports medicine and shoulder reconstruction. I performed my residency at the University of Pittsburgh Medical Center under the guidance of Dr. Freddie Fu. I then went on to perform a sports medicine and shoulder reconstruction fellowship under Dr. Richard Hawkins. So that is our faculty. I currently practice in Tampa, Florida. I'm a faculty member at USF for the sports medicine program, as well as our shoulder reconstruction program, and I'm a partner at the Florida Orthopedic Institute. So getting right into our talk tonight, we're going to talk to you about the use of Tactoset in shoulder repair about the shoulder. The problem that we're dealing with in this situation is really insufficient bone or bone defects in the shoulder when we're talking about repair, either that be around the humerus or in the glenoid. When we look at deficient bone in the greater tuberosity, the problem is really poor bone stock. When we look at poor bone stock, we can look at this in several different manners. One being cysts around rotator cuff tears, osteoporosis in the face of rotator cuff tear, revision rotator cuff repair. We also see use for this in places like non-displaced fractures that go on to non-union or AVN, or even in the case of a dislocation where we have a Hill-Sachs lesion and we plan on performing a remplissage procedure in this defect. Currently, when we run into these issues with poor bone quality and we place our anchor and we pull the anchor out, we look to our rep in the room and we say, give me a larger anchor. So if we had a 4.75, we say, give me a 5.5. You put that one in, it pulls out. I'll take the 6.5. That one pulls out. At some point, you run out of anchors, okay? Luckily, we've had guys that have run into this before most of us, and under the tutelage of guys like Dr. Denard and Burkhart, we have guidance for options for this. And currently, most of us will try to go to some of these options, such as stacking anchors or a buddy anchor, which to me really is just an interference fit. And we're trying to basically create friction and prevent pullout. Another option is the rescue anchor. The rescue anchor is basically finding an alternate place to place that anchor that has a little bit better fixation. In my practice, the bicipital groove tends to be that place. So I'll tend to place anchors somewhere around the bicipital groove to try to give me some backup fixation. Once those things run out, now we start trying to do things like medializing our footprint. So I'll take down the cartilage, try to place the bone into that subchondral bone of the humeral head, which usually will get you a pretty good bite. Once you run out of those options, now we're down the road. Now we're getting into open bone grafting. And eventually, if you don't play your cards right and you're not prepared, I've seen patients walk out of the operating room with a reverse total shoulder when they actually went in for a rotator cuff repair. Luckily, this hasn't happened with my patients, but I have seen it with other physicians. Other options for treating bone injuries, AVN in the humeral head. This is typically an idiopathic process, or even treating bone marrow lesions in the degenerative shoulder. Current humeral head options revolve around really symptomatic treatment typically. Usually we're using medications, injections. Sometimes we'll resort to bone decompression or drilling to treat AVN. Bone grafting are options as well. Typically we'll progress on to arthroplasty though. We'll start treating these things with hemicaps or even a total shoulder arthroplasty to try to treat this deficient bone. The glenoid is another area of the shoulder where we have difficulties with management, especially with poor bone quality. These are typically in the face of labral tears with full thickness chondral defects, revision, labral repair, and even bone marrow lesions or degenerative arthritis, such as seen in the bottom right picture here. Current glenoid treatment options are all pretty aggressive in these cases. Most of these are done performed open, such as an autograft with the iliac crest bone graft. We'll see folks that use a Latarjet procedure or a distal clavicle transfer. Allograft options are also an option when we get into the distal tibia, utilizing the allograft. And then even the Glenoid is an option for you, where you're using allograft to reconstruct the glenoid, most typically anteriorly. And that's just another example of treating these options in an open manner. So the point of this talk really for me is I really sought easier options for this. Currently the options that we had were not all that resourceful, not all that dependable, and commonly very aggressive. They burn bridges and were open procedures. I really sought an option for arthroscopic options, percutaneously performed, that would allow me for a revision at a later date if things did not work out. When we look at Tactoset is a synthetic biocomposite hyaluronic acid. It's a calcium phosphate bone void filler that is essentially a natural graft bone substitute material. It is made for the use of filling bone defects that are not intrinsically important to bone stability. The good news about this material is that it's resorbed and replaced by bone and allows for new bone healing to occur during the healing process. It's injectable in a percutaneous manner. It's self-setting, typically in about 10 minutes. It's osteoconductive, which means that your normal bone turnover will basically react to it and turn it into normal bone. And fortunately for us, in the case of repair, it is drillable. It's commonly used for fixation of injuries to the knee and the foot and ankle. Those are the most common uses for this. It is used typically in these situations to treat microtrabecular insufficiency fractures. It's highly porous, which is important. You want something that is porous so that it can undergo rapid bone turnover. If you have something that is very dense, like a cement type of PMMA type of issue, you won't get turnover of that material. You also want the compressive strength to be something similar to that metaphyseal bone that you're using to repair. And that is the compressive strength of Tactoset at 8 megapascals, which is typical of metaphyseal bone. To give you an example of use of this is a 49-year-old gentleman of mine, 6 months of right-sided shoulder pain. He's failed injections, he's failed therapies, and I'm concerned now that he has a rotator cuff tear. On the AP view, you can see that he has a little bit of a cystic formation on the kind of middle portion of the greater tuberosity. On the AP Grashi view, he has no degenerative changes and no proximal migration, but you do see some degenerative changes at the greater tuberosity. The scapular Y view doesn't show much going on there. And then the axillary lateral shows a well-centered non-arthritic joint. The MRI really tells us the whole story, though. On the far left axial picture, you'll see a large cystic lesion in our greater tuberosity. On the sagittal lesion, you'll see, or sagittal view, you'll see again that large cystic lesion. Directly above it is our full thickness rotator cuff tear. And on the coronal view, again, you're going to see a large cystic lesion directly beneath our full thickness retracted rotator cuff tear. So having failed conservative management, we determined that we would perform a procedure for him in the form of a rotator cuff repair. So we weigh our options. Do we wish to try to avoid this cyst? Do we want to place our anchors in alternate positions? Do we want to try to use larger anchors or bone graft this thing? In my case, what I typically do and has become standard for my practice is we perform a fixation of the defect with our calcium phosphate implant with Tactoset, and then we'll proceed with our normal repair. So this is a video that's unedited. It is a real-time video that we performed. You can see we're placing our pin into position. Each of those pinholes, we want to be just beneath the cortical bone. And we're going to remove the inner stylet and we're going to inject the calcium phosphate material. We're going to place this material until we start to see an egress of the material. You'll see a little bit come out there. That means I've typically filled enough of that cyst that I can probably pretty much stop and wait at this point to allow the material to set. I'll place my shaver in the joint. We're happy that this material will stick to itself in the fluid. So you don't have to worry about making a big mess. We'll simply turn on our shaver. It'll bring the material back into the arthroscopic shaver. And then we'll perform our standard debridement of the tuberosity. We'll perform our releases of the rotator cuff and get ready for our repair. Typically that takes at least 10 minutes, which is about the setting time of the material. So we'll remove our pin at this point. We'll then remove any of the further debris that's in the subacromial space. And then I'll take the scope out and just look down into the hole to show you that this defect has been filled. I've targeted this lesion by measuring off of the bicipital groove in the bicep. You can see here the fill is very nice. We've got a nice stiff fill of calcium phosphate in that defect now. So we'll just progress from this point to a standard rotator cuff repair. Now that's in the face of a cyst. This is a patient with osteoporosis. So in this case, what I'll do is I'll actually just target the center of the greater tuberosity. We'll place our pin into position and we'll start to eject, and you'll notice immediately egress of blood. This will be then followed by fat marrow element. And then once these fat globules stop flowing, I typically will stop injecting the material. Now, I'll typically spin my pin around as I'm injecting it. It doesn't probably make that much of a difference, but it makes me feel better that I'm distributing in some way. The key is to be just subcortical though, because we want that material. You can see the calcium phosphate right there in the subcortical bone. It really creeps along the cortex if you stay just in the subcortical region. So once we've got that in, again, we'll wait 10 minutes while we're prepping our tuberosity and mobilizing our repair, and then we'll do our standard rotator cuff repair afterward. So the question is, what does this become over time? So 6 months follow-up on this gentleman. You can see here on the axial views, this is the pre-op on the top, all three views, and then on the bottom is 6 months post-op. We've got a great fill of that tuberosity lesion on the left. On the sagittal views, again, the great fill of that lesion. You're not going to see a complete fill of the cyst because you haven't excavated the cyst. A lot of times these cysts are not really fluid filled. Sometimes they're actually more fibrotic or gelatinous. So sometimes you'll get just enough to allow you to get good purchase in there, as is the case here. But we have an intact rotator cuff at 6 months with the defect being filled. When we look at calcium phosphate use in the shoulder and look at the literature, we've been working on this for several years. And if we look back at the AccuFill series back in 2019, we actually published our first 2 patients on this. Some of you may be familiar with AccuFill. It's the calcium phosphate material made by another company. It has similar properties to Tactoset. And in this case, we presented our first tuberosity lesion as well as our first glenoid lesion. And this was published in the Techniques of Shoulder and Elbow Surgery in March of 2019. The first patient was a 50-year-old female who presented with 1 year of shoulder pain. She underwent a brief course of conservative management with injections and therapies and really saw no improvement in a 6-week period. As you can see here on the AP view, there's a large cystic lesion. On the AP Grashy view, again, a large cystic lesion with reactive changes to the subacromial space, likely consistent with a chronic rotator cuff tear. The axial views, the axillary laterals show no arthritic changes and no instability. And then the scapular Y view, again, pretty unremarkable. The MRI gives us a lot more feedback as to what we're looking at. 2 cystic lesions in the greater tuberosity on the axial view. Coronal views show that cystic lesion with the rotator cuff tear above it. And then on the far right, the sagittal view, again, with these 2 lesions in the tuberosity. So in this case, again, you really got to think about your planning in this. Are you going to plan on placing your anchors in a different location? Are you going to go with a larger anchor? Are you going to bone graft this? Again, in our case, we perform percutaneous fixation with a calcium phosphate implant. Again, on the top, this time we have all of our post-op views at 6 months. Again, the MRI shows great fill of these lesions, both in the axial, the coronal, and the sagittal views with an intact rotator cuff over time. Our second case that we presented in that published study was of a 22-year-old male. He came in with symptoms that really seemed more like a labral lesion. So we actually treated him with an intra-articular injection. But you can see here on the axillary lateral, there's a large cystic lesion in the posterior aspect of the glenoid and some changes that you can even see on the AP view. MRI really elucidates what we're looking at here. Again, on the axial view, a large cystic lesion taking up nearly 50% of the posterior glenoid. On the bottom right X-ray or MRI on the sagittal views, a large multilobulated cyst in the posterior superior glenoid, and then on the coronals, again, that cystic lesion. I wanted to better understand this, so we did obtain a CT scan in this case. Again, the CT shows me really what's going on here. What I'd like you to really look at is the subluxation of the humeral head. We really have about 50% of the humeral head is posterior to the midline, actually maybe even a little bit more. We're even starting to see a little bit of osteophyte formation, again, in a 22-year-old guy. So we had discussions with this young man. I think this was around 2016, 2017 when we performed his surgery. And we discussed with him that we really don't have good options other than large, open, aggressive options, that we had calcium phosphate injectable option, and he elected to proceed down that road. This is him at the post-op period. Again, I'd like you to kind of focus on the fact that the humeral head is now centered. So as you look here, we've centered the humeral head. We filled our lesion with the calcium phosphate. We performed a labral advance and a posterior capsular plication that allowed the humeral head to be centered more, and treated him as a standard posterior labral kind of repair. Again, these implants are going right through this calcium phosphate. 2-year follow-up at this point in the study with sustained results and function. 6-month post-op MRI, again, showing incorporation of that calcium phosphate with the humeral head relatively well contained and no real recurrence of our cysts. When we looked further in this, we really wanted to show in the AccuFill series that the AccuFill actually did what we thought it did. And what we thought we were doing was increasing our pull-out strength of our anchors. So, my goal was primarily to fill the defect, but then obviously I wanted to augment the fixation of my implant. So we designed a study looking at both a bone foam model as well as a matched cadaveric study. And what we looked at was basically injecting half of our bone foam models with the calcium phosphate implant, and then the other half not being injected at all, instrumenting them and then performing pull-out studies on the bone foam. Now, this is 7.5 PCF foam. It is meant to mimic the osteoporotic state. Most bone foam that we work with is 15 PCF, just to give you an idea. And what we found in this study is that the AccuFill group basically doubled our pull-out strength with a threaded suture anchor construct. So when we looked at ultimate tensile strength, those implants that received AccuFill had about a doubling of the pull-out strength. And then when we looked at the matched cadaveric study, one with and one without AccuFill, and then instrumented with a threaded suture anchor, again, we had about a doubling of the pull-out strength with the AccuFill group. So with Tactoset, we were wondering, are we seeing the same results with this? Now, this study is not published yet. We have submitted it for a publication in arthroscopy. It's currently undergoing review in arthroscopy, but we really did the same exact thing. We did a foam block study using 7.5 PCF foam. We then did a matched cadaveric study looking at left and right humeri of the same patient, and then instrumented with and without the Tactoset. And what we found in the foam block study was actually very similar, if not maybe even a little bit better than what we saw with AccuFill. And what we also did in this case is we used an all suture anchor. Many surgeons are now converting to all suture anchors. And what we wanted to see was, are we actually increasing the strength of the all suture anchors? There's been some thought that with these calcium phosphates, we actually might reduce the pull-out strength of an all suture anchor because we're not setting the construct. In this case, what we found with the draw tight anchor, an all suture anchor construct, that we did increase our pull-out strength by over 50%. When we looked at a biocomposite threaded suture anchor, by more than double. And then in a peak threaded anchor, the twist peak anchor, again, more than double, almost triple the pull-out strength in a foam block model. When we looked at our matched cadaveric study, what we looked at was the composite anchor and the peak anchor, both threaded anchors. We did not perform the all suture anchor, just from a cost perspective. And again, what we found, similar results. In a matched cadaveric study with Tactoset, we found that in our twist composite type anchor, we had more than doubling of our pull-out strength in a matched cadaveric study. In the twist peak anchor, the threaded peak anchor construct, we had more than 4 times of our pull-out strength by adding the Tactoset to a matched cadaveric study. So similar, if not better, results utilizing the Tactoset as we had experience with the AccuFill. So in summary, when you're dealing with deficient bone in the shoulder, whether it be related to cysts, whether it be related to osteoporosis, revision, reconstruction, labor repairs, you need to think about what your options are. And for us, as our primary option for this, we like to use Tactoset. It's minimally invasive, performed through a percutaneous poke hole. It sets in about 10 minutes. It's drillable at that time, and it doesn't burn bridges. We've had pretty good results with this over the past several years, and we'd recommend that you give it a try if you have patients that are applicable to this. So I wanted to thank you for your attention. At this point in time, I'm going to hand this over to Dr. Ashraf, who's going to review some more cases with you.
Thank you all for joining us for this masterclass regarding Tactoset for augmentation for rotator cuff in the setting of a poor bone quality patient. Thank you, Dr. Baker, for an excellent presentation. And I will take you through some cases of mine where using Tactoset in patients with poor bone quality. Factors leading to anchor failure could be from preoperative and intraoperative state. We look at bone density, osteopenia, and osteoporosis. Studies have shown that when there is a full thickness rotator cuff, the greater tuberosity is not stressed and can decrease in bone density, leading to softer bone, osteopenic bone. We already discussed with Dr. Baker cyst in the greater tuberosity, and as we use more anchors and different configurations to fix our rotator cuff in the greater tuberosity, the stress on this osteopenic bone can be troublesome. Other factors intraoperatively, such as overtensioning of sutures, angle of insertion of the anchor, can all decrease pull-out strength of our anchors in the greater tuberosity. Patient factors such as smoking, diabetes, can also lead to anchor pullout and decrease strength. Surgical techniques such as aggressive decortication of the tuberosity can also lead to anchor losing strength for pullout strength. And of course, patient compliance. We just don't know what our patients are going to do. And this is one factor that we can use to see if we can add some extra insurance for anchor placement. We have been taught to use decortication as a method to decrease calcified bone on the greater tuberosity to increase blood flow to allow for increased healing of the rotator cuff to the tuberosity. But by decorticating the bone, the side effect is a lower pullout strength for our anchors and can lead to a deeper insertion of the anchors, leading to anchor pullout. What I'll review in this presentation are some pearls and pitfalls of using Tactoset in the rotator cuff, as well as review some case presentations. The Tactoset can be used in your regular setup, beach or lateral. Does not have to change the way you do this procedure. Standard arthroscopy setup. A fluoroscopy can be used for the first few cases as you get comfortable, but really doesn't need to be used for every case. And if you do need to have a drill available, which is something we usually don't have available for rotator cuff repair. I do my cases lateral, and I really don't change any setup except the drilled power box. Patient selection is very important. You can determine this preoperatively based on MRI, looking at greater tuberosity cysts, subchondral edema, and even the level of retraction of the rotator cuff. Large chronic rotator cuffs cause osteopenia in the greater tuberosity. Medical factors such as smoking, comorbidities, post-op compliance, as well as history of osteoporotic fracture, distal radius, proximal humerus, even hip fractures. These patients have shown that they have softer bone and can likely use some type of augmentation for a rotator cuff repair. Where I use most of my Tactoset is from intraoperative considerations. As I'm decorticating the bone or placing an anchor, when I find that the bone is not soft and I have to turn to a larger anchor, this is when I'll start using Tactoset and mixing my Tactoset so I don't have to compromise the position of the anchors, the number of sutures, or how I rehab the patient postoperatively. Because a lot of times when you run into softer bone, what we tend to do is leave them in the sling for longer and delay their rehabilitation process. But the use of Tactoset intraoperatively, really you don't have to worry about anchor pullout, and you can continue their rehab protocol as you would do normally. So the surgical procedure overview is arthroscopy, and normally I'll start mixing the Tactoset at the beginning of the case if I've determined this preoperatively. And you deliver the Tactoset, and after you deliver the Tactoset, inspect the joint to make sure you have not perforated into the joint or you haven't injected into any other plates besides the greater tuberosity. What I often do though is I decorticate the bone and I get a feel for the tuberosity. And if I do find that tuberosity needs some Tactoset augmentation for anchor pullout or for soft bone, I make a small stab incision using 11 gauge and get the same angle that I would do for my anchor placement. Once I do that, I use my drill. And again, as Dr. Baker pointed out, right below the subcortical bone, maybe the first or second laser line. Once I do that, I use the targeting device and get a 360-degree circumferential Tactoset placement around the planned anchor site. Once the Tactoset is injected, I leave the drill in for approximately 2 minutes while the Tactoset cures. So again, it does not change your surgical process. You drill exactly where you want the anchor, and once you have found the correct position, you drill right into the area where you plan to place your medial row anchor. There's two surgical techniques and methods that the Tactoset can be used during a rotator cuff repair. One is one we just demonstrated, where it's placing the anchor into the Tactoset drill hole as shown in this animation, where you drill, wait 2 minutes, and then place your medial row anchor. The one that I do more often for larger repairs is placing the tactile set in a central position around the greater tuberosity and really use the targeting device to target my medial and lateral row anchors. And what that allows me to do is fill any greater tuberosity, cyst, bone voids, but as well as really get a great coverage of that whole footprint of the greater tuberosity for anchor, which I normally use 3 to 4 anchors for a rotator cuff large repair. This question I get all the time is how much tactile set to inject, and really less is more when it comes to tactile set in the rotator cuff in the greater tuberosity. So usually somewhere between 0.7 to 0.8 cc's, and really targeted around where your anchors are going to be. You will yield approximately 4 cc's of tactile set from the kit. And for the first syringe, if you inject the full syringe, only about 0.2 actually make it into the bone. The rest are in the cannula. You have two options. You can use a plunger to get the rest of it into bone, or you could use another syringe and inject under direct visualization. My recommendation is to use a second syringe because as you're pressurizing, you can actually see that egress where you know you have injected enough. And again, less is more when it comes to tactile set in the greater tuberosity. This is a case of a large retracted rotator cuff tear. I decorticate the tuberosity. After decorticating the tuberosity, I've determined that the bone is soft. You can actually use the back of a shaver just to feel how soft the bone is. And once that's completed, I've decided in this case to inject into my medial row anchor, where I plan to use a triple loaded medial row anchor. So as I'm injecting the medial row area with the tactile set, you could see the first and second laser line. I will have direct visualization to make sure there's no perforation of the tactile set or the drill into the glenohumeral joint. You'll also see the egress. Once you have seen the egress, you can really stop injecting. Using the targeting device, I'll target also the lateral row, but for this case, I'm using a side targeting device and working 360. And that's once you see that, you've injected enough, and you can then complete the rest of your rotator cuff repair. At this time, if once I see the egress, I'll increase the pressure in the shoulder using the fluid management system by about 20. And what that'll do is really keep the tactile set contained within the tuberosity. Another large rotator cuff tear, you can see the angle of which your drill is coming. You can see the egress of the fluid subcortically, anchor placement, and your suture passage. Again, this is a technique where you're injecting into the area where you plan to put your anchor in. This is a 50-year-old laborer, large retracted rotator cuff tear, and he's anxious about returning. And I know he's not going to be compliant with my post-op rehab protocol. So there's everything I could do to help this guy get back to work. So you could see a large retracted tear. In this case, I've injected into the greater tuberosity a center position between the medial and lateral row anchors. Once I've injected the drill, you can see the laser mark, first and second laser mark. And once that's completed with the outer drill, I will then take the side targeting guide. And using the side targeting guide, I will target the anterior medial anchor, posterior medial anchor, as well as the lateral anchor. And again, about 0.7 to 0.8 cc's under direct visualization, you will see that egress, which again marks that you have likely put in enough into the greater tuberosity. And you start seeing that egress. Once that's completed, and this repair, I've put a few side-to-side stitches, and then I've passed all my sutures through the tuberosity. I feel confident in pulling the rotator cuff, putting tension on the anchors without any worries that the anchor will fail. Before I go into this video, this is a rotator cuff repair, large tear. And the purpose of this video is to demonstrate how I prep and the advantage of using tactile set to prep the tuberosity along with nanofracture, which channels and microfractures of tuberosity in preparation of the greater tuberosity bed kind of setting us up for success for rotator cuff healing. So I'll let this play. Here, using a shaver, just debriding the large rotator cuff. You can see there's some lateral tissue left. In this case, in the preoperative MRI, there was a large greater tuberosity cyst at the attachment site of the supraspinatus. I don't decorticate as aggressively as I used to in the past. Now I really just take a shaver and take any loose tissue off that greater tuberosity. Once that's completed, I'm coming in at the dead man's angle to get my angle for my Tactoset injection. And once again, picking a center position between the medial and the lateral anchor placement. I drill into the greater tuberosity where the cyst has been shown in the preoperative MRI between the first and second laser line, using the drill also as a tactile feel to make sure I'm within the bone and not perforating. Once that's completed and I'm injecting, I will increase the pressure of my fluid management system by about 20 and then remove the drill about 2 minutes later. Once that's completed, we inspect the joint, making sure there's no calcium phosphate Tactoset within the joint. And then you can go on to microfracture, and in this case, using a nanofracture, which channels the tuberosity, making smaller but deeper holes about 9 millimeters. The advantage of using a Tactoset in this setting is with the hyaluronic acid makeup, you really get better interdigitation, better flow into cyst and the trabeculi, and great feedback from the injecting of the Tactoset. You also get the targeting device and the ability for the hyaluronic acid to really help turn this into bone sooner. And once that's completed, you have now completed the tuberosity prep, and you can now do your rotator cuff as you would normally. And in this case, I would use a medial row anchor, a few side-to-side stitches, and a few lateral row anchors. So some tips and pearls, I think it's important once you start mixing your Tactoset to wait approximately 7 minutes to make sure it is in a paste-like consistency. It really helps keep the Tactoset in a form that's easy to inject, provide good feedback, as well as so it doesn't extravasate. You're important to get a proper angle. If you come in at too steep of an angle, you have the chance of perforating into the joint. So it's important to get the perfect angle, and you can use your arm positioner in the beach or lateral position to really feel the bone and use the laser marks on the outer drill between first or second laser line to know the depth of where you're injecting into the greater tuberosity. It's important to inject on direct visualization. It shows you if there's an extravasation. It also shows you when you've injected enough because you see that egress in the greater tuberosity. Increasing the pressure of the pump by 20 to 30 does help. Again, it keeps the pressure in and it avoids that the egress, aggressive egress of any fluid or Tactoset. Again, injecting less is more. 0.7 to 0.8 cc's is likely all you need to inject around the greater tuberosity into the anchor site to provide stability of that anchor and increase the pull-out strength. And leave the drill within the greater tuberosity 1 to 2 minutes. And once that's completed, do a really great inspection of the joint to make sure you have not injected into the joint. And then you can do your rotator cuff repair as you see fit. Thank you. Great. Thank you all for attending the Tactoset conference here today. I want to thank you, Dr. Baker. Thank you, Greg DeConcilius, for being here today to answer some questions. And so really, I'm going to focus on, I'll start off with you, Dr. Baker, is you've used other products before with Tactoset. Can you comment on the injectability and the tactile feel with Tactoset that you find important?
Yeah, thanks for the intro. Great talk as well. So, in my mind, there are really only two on the market that act like this. There are published studies with PMMA and other types of materials. Those are not in this class. So I want to make sure that we distinguish between the two. It's essentially this and AccuFill that is, to my knowledge. I've used both. I don't really feel much difference in the way they act. The one thing that I'll say is I commonly get a question of, can you get a tactile feedback of when it's full or when you should stop injecting? And my answer would be no. As long as it's liquid, it'll continue to flow. And if you're not careful, you'll actually fill the humeral canal. Just to your point as well as about the depth of insertion, if you put these insertion pins too deep, all of your material will end up in the central portion of the humerus, not in the tuberosity. You got to remember that it follows fluid dynamics, so it's going to follow the path of least resistance. And if that path is the canal of the humerus, the central canal, that's where all your material will end up. So just kind of be cognizant of that.
Great. As far as the amount and the location, I think it's important as far as the technique to wait that 7 to 8 minutes to wait for that tactile set to get into this paste-like material. So as you're injecting, you can visualize it and only inject about 0.7 to 0.8 cc's up to a cc based on the size of your greater tuberosity cyst or the size of your footprint. A lot of questions, for this is for Greg DeConcilius, is about pre-authorization, and the talk is what language to use, what phrases to use to get this pre-authorized if you know you're going to use Tactoset preoperatively. Any thoughts?
Yeah, thanks. I think the key is to really be as specific as possible in that, in that description, when getting off to the pre-authorization department. MRI findings, again, specific findings, and, description of kind of what you're doing. We talked a little bit about, kind of the elements of kind of what it takes to, the indication, this type of thing. So anything you can provide to them, and it may take a peer-to-peer. It may take a point where you have to actually call and speak to a medical professional to get this thing kind of pre-authorized. But it is kind of a must. And again, we always advise to kind of be as specific as possible. And if you find kind of similar results, kind of in your pre-authorizations.
Yeah, so I'll let Dr. Baker, please.
Yeah, so in my mind, I think you're right. You need to build your case in the office generally. I mean, a little bit different than Dr. Ashraf. This is almost always a preoperative decision for me, because if it's a cyst, I know I'm going to use it. I try to measure my volume of that cyst on all three views. That'll help me kind of calculate. I'll then describe what it is as a bone void. I'll describe the need to address that. And then I'll simply just say the steps that I do in my operative report. I mean, I'm making accessory portals. I'm bringing in a new material. I'm allowing that implant to set. It's filling the void. It's filling the fracture. It's filling the osteoporotic bone, whatever it may be. And that's kind of how I document it. I like to build almost all of these as a 22 modifier. So, for those of you guys who understand billing, I'm sorry for the details, but I'll just kind of give you thoughts on how I code these. So in a shoulder, most of us do 3 or 4 codes. And so your first code is going to be paid at 100%. Your second code will be paid at 50%. Typically your third is also at 50%. Once you get down to your fourth code, you're about 25% reimbursement on your CPT code. And so adding a fourth code or even a fifth code is a wasted code that won't get reimbursed. Getting 25% back on a code or losing like my subacromial or my distal clavicle isn't interesting to me. So I build this as a 22 modifier to whatever I'm repairing. So if I'm repairing a rotator cuff 29827, I'll add a 22 modifier. I'll then send a separate note with my bill or with my dictation from my surgical note that describes why I believe it's at a higher level of difficulty. So a 22 modifier is a standard repair, but with more difficulty. And by the use of extra portals, accessory cannulas, new implants, all of those are the exact definition of what a 22 modifier is. And then you define what you think it should get. So if you make $1,000 on a rotator cuff repair, just as a generic number, you can ask for 50% more for that. that's going to get you more in reimbursement than adding a fourth code. So I think a lot of guys worry about what type of code. This is a very clean thing, whether you're doing a revision rotator cuff repair, whether it's a massive that requires a dermal graft, or whether you're doing a cement augmentation or calcium phosphate augmentation. 22 modifier is by far the cleanest way to build these types of procedures.
Yes, Dr. Baker, I couldn't agree more. I think preoperatively, in your preoperative note, you could talk about patients, smoker, history of osteoporotic fractures or MRI findings, but it's the intraoperative note describing why you want to use or you did use Tactoset. And to kind of add on to what you said, the other two additional things I think that are important is to talk about the time it took, and the way I ask for 50% more reimbursement is to say that because a standard rotator cuff takes me 45 minutes due to osteoporotic bones, subchondral cyst, and patient-related factors, using Tactoset added extra time, an additional 25 minutes, 15 minutes, whatever the case, to really find out why this should be reimbursed at a modifier 22. And that is definitely the way I bill for this in my OR in the hospital as well as the ASC. A little technique question for you, Dr. Baker, is when you're using your Tactoset, are you injecting it into the cyst or where you think you want your anchor to go? And how do you decide?
So to me, those are two different questions depending on the patient. So if the patient has a cyst, my whole goal is to target that cyst. So I'll typically measure off the bicipital groove, I'll measure off the articular surface, and that kind of gets me to that cyst. And I'll try to measure even the volume in 3 dimensions on my CT scan or MRI or whatever I have. For an osteoporotic shoulder, I typically will just place it right in the center of the tuberosity. I try to get as close to the subcortical bone as I can. And just like in your video showed, just like in my video showed, you'll see egress along the entire tuberosity, and you'll see bubbles come out of fat and then blood, and eventually it'll stop coming. And once that stops flowing, you've basically replaced a good portion of that area, not all of it, but a good portion of it with the calcium phosphate. Now, I'll tell you, the very first one I did that we published back in 2019, my hand partner was actually in my room and kind of chirping me up a little bit. What are you doing? You're going to mess up the healing and everything. And as soon as I did the calcium phosphate implantation, I made my punch hole, standard punch for an anchor or a tap or whatever you use. And immediately I had marrow elements coming from deep within that. So you're not choking off blood supply. You're not messing up the biology. To be honest, the vast majority of these that I've ever done have done great and have not had any recurrences. Now, I've had a few massive tears that I've done this for that fail. Obviously, we know that occurs, but I've had no AVN in the proximal humerus. I've had none of those types of issues. I have experienced some of that in the knee in the early days when we used to inject way too much volume. But in the shoulder, I just have not had that because like you say, I'm typically using, if I'm doing a whole tuberosity and I'm really worried about osteoporosis, I might go up as high as 2 cc's. But typically in a cyst, it's like 1 cc or less if you measure it.
Great. That's answers a few questions on the Q&A box. Greg, a question for you about, you kind of run your own ASC, from a perspective of a business as an ASC. You look at someone who has osteoporotic bone, an anchor pulls out, you put a bigger anchor in, that pulls out, now you're putting buddy anchors in, or having the option of using Tactoset. I mean, what's the cost benefit, the savings cost benefit? How do you see it as a business and an ASC?
Sure. The nice thing about the use of Tactoset in this, in this particular case in the shoulder, we can bill an additional code for it, and for me, there's obviously reimbursement, and again it can be reduced, et cetera. But even at the rates that reimbursed to an ASC, it's pretty significant. And so if we did it kind of in pre-op plan and we used it, I'd be fine with it because the rates are the rate of reimbursement is sufficient enough to kind of cover the cost of the implant, cover the time to do it, et cetera. But as you're saying, in an intraoperative decision, I also would prefer to use the Tactoset, build the additional code, again, you guys can build a 22 modifier on your side of it, and then get that reimbursement. If I'm using extra implants, there's obviously more time associated with that, and oftentimes our implants and ASCs, at least in Massachusetts where I am, those costs are kind of baked into, or kind of bundled into, if you will, our reimbursement per CPT code. And so I'm not getting any additional money for that case anyway. The rotator cuff is 2927 either way, no matter how many anchors they're using. So I always want to use kind of less implants, or in this case, all day long, use a tactile set. Again, I think it's better for the patient. That's the number one thing, right? If we're getting reimbursed or not, but, better for the patient. And then in addition, you can have secure implants, a great repair, and I can build an additional code. So I put my business hat on, and I'm happy all around.
So talking about that code, Greg, kind of going back to the way we were trained on the knee is using a calcium phosphate for a fracture, subchondral fracture. So the code that could be used for a proximal humerus for subchondral edema, osteoporotic fracture is 23650, which is a arthroscopic fixation of a proximal humerus fracture. So that's a code that can be used and can be pre-authorized in the right patients. Would that be correct?
Yes, correct. And and I think it's interesting you mentioned about kind of getting this, maybe preoperatively you visualize it and you say that I'm going to use this, but what happens if you intraoperatively you do it? So do you get it pre-authorized on all of your patients, or again on maybe older patients, or certain patients, certain comorbidities? It may be something you want to look to, but again, in this world of authorizations and prior authorizations, it's something that's not going to reimburse after the fact. So is it smart to kind of look at this ahead of time? It might be a good move.
To support a little bit of the backside office side, I think it's important that the surgeon understands the contracts that they're working under. So, in the hospital, you have a lot more freedom. The reimbursements are high. So even if your contracts are not great from a standpoint of carve outs where you're going to get reimbursed for implants, the reimbursement rate's about double at a surgery at a hospital what it is at an ASC. So if you have issues where your contract is going to get burned at the ASC because you have these capitated plans, then you really probably need to consider whether you should bring these to the hospital. But if you have these conversations with your ASC leadership, you might find that a lot of them are applicable. We're still lucky at our center where most of our private payers have carve-outs. So my group is happy for me to use more anchors. They're happy for me to use more implants. That's probably a rare bird, but I do have different providers that are insurers that do not do that. So I need to be cognizant as a surgeon, both clinically, but also financially and business wise.
Sure.
Are you able to see, Dr. Ashraf, the Q&A thing there? Are you looking at that?
Yeah, I am. So you mentioned that, Chris, is that in even two different states, I work in between New York and New Jersey, and the different anchors and the amount of anchors that can be reimbursed or the carve outs can change center to center from location to location. One question, I guess, for the group is any reaction to the tactile set, inflammatory in patients that you've used it for? What's the safety profile in your hands, Greg and Chris?
So for me, all Acufil, all Tactoset, all calcium phosphates that I've used, if you go back to when I started this in probably 2014, maybe, I've probably done 500 plus, 600 plus of all these. I've never had an infection. I've never had an abnormal reaction. When we were first starting out, these things came in big kits of 5 cc's, and it was expensive. So we were just pumping 5 cc's in everybody. That was not the right thing to do. So if you're dealing with like an AVN situation, something where you're concerned about blood flow, definitely be very careful with regards to how much volume you're doing. I think that's the only real negative you can do. Now, that being said, as a guy who was starting to get referrals from this of people having questions and that kind of thing, when they had problems, they started sending me patients. So I did have one patient that did have an infection in a tibia. He put in way too much material. I believe that the patient went on to have a little bit of an AVN issue, and then ended up becoming infected. I think it was irrespective of the implant. I actually opened up a bone window, took it out, placed the bone window back in, and almost like a tibial plateau fracture from beneath. And he did fine. We've got him through it, and he did well. But I think obviously you need to mind sterile technique. I think that's the only issue. If that happened in the shoulder, obviously if my rotator cuff had healed, I would leave that and I would do something similar to that. I would go lateral to the tuberosity, try to make a bone window rather than take apart my my repair.
Great. One question is about the cyst that we talk about in the greater tuberosity. I think a greater tuberosity cyst without a rotator cuff tear, asymptomatic cyst, I don't think anyone would aggressively go after surgically. I think the cysts that we're talking about in these case scenarios are the ones where there's a cyst where you are thinking about putting an anchor for fixation. And the idea is if you fall into a cyst and now you have to compromise where you put your anchor, more medialized, even the number of sutures and what tension you put, those are the cysts that we're thinking about injecting, kind of filling, getting great fixation and not compromising even the rehab. Because there was a question to Greg and Chris is why inject a cyst? Can't a new cyst form around the tactoset? Any thoughts on that?
So again, I think this is to Dr. Brannon. You know, when we look at these cysts, they are part of the pathologic process of rotator cuff tears. And if you look at the literature, there's actually some pretty decent data on cysts being involved in rotator cuff tears. It's up to like 50% in some studies, depending on the patient population. The problem is that those cysts, like many other cysts, become walled off, right? So just like if you have an infection in an abscess and there's an abscess wall there, your antibiotics can't penetrate, the cyst will remain there in perpetuity. Once the rotator cuff defect is torn and the cyst is there, it's pretty much not, it's benign, it's just sitting there. So it's a fixation issue. And what I try to do is when I drill through these cysts, I actually try to drill bicortically a little bit if I can without getting too deep, because now I'm allowing the body and the natural healing process to enter the cyst. And now I've created a scaffold that the body can go through and heal these on. I have some more remote imaging on CT and MRIs that shows complete resorption of these, complete remodeling along the calcium phosphate channel, and really good looking X-rays, MRIs, and CTs. So I would disagree that we're kind of, once the tear occurs, the cyst becomes benign other than for fixation. And now what we're doing is we're actually giving it some biological capability to be healed.
Right, agreed. Greg, a question for you. You know, we're talking about reimbursement. You know, for the modifier 22 as an ASC, as a surgeon, we get reimbursed a little bit more. But from an ASC to cover cost, you know, the question is what code can be used? And I think, you know, we talked about that fracture code. Is there any other codes that could be used?
Yeah, no, and I already looked at 23650 and 23630. I mean, I think that's really, those codes are going to be sufficient enough. I think if you go back and talk to your ASC leadership and see, you know, what that get reimbursed for, even from, again, a Medicare, a Mass Health perspective. And we looked at all of those, and their reimbursement is pretty adequate. Again, as we talked about earlier, we don't get reimbursed for the 22.
Great. Another technique question is, you know, and I'll start this one. The question is, have you ever punched for an anchor, and as you punch for the anchor, fell into a cyst that you didn't recognize on preoperative images? And then what do you do? And so the technique for this in my hands would be if I punched into an anchor and I'm in a cyst, I would stop there, inject that cyst and inject it slow. You know, you definitely want to do it slowly under direct visualization to prevent a lot of egress or any egress of the tactile set into the joint. And as you are filling the cyst, you want to increase the pressure of your arthroscopy fluid management system to kind of keep it contained. And you want to wait about 1 to 2 minutes. Once the tactile set is hardened, as Dr. Baker said, you go back in and you punch like you would normally, and you'll find sometimes you even have to tap for the anchor you want to use. So it does add a few extra minutes. You fall into the cyst, you start mixing your tactile set. 7 minutes is what you need, and you can go back to the rest of the case without compromising your anchor position or your rehab.
Yeah, so it looks like a couple of folks, Tom Sweeney, Daniel Donahue, are both kind of keying on this. So this is what I'm trying to avoid, right? So in pre-op planning, which I think we all need to do, and some of us maybe don't do enough, you can avoid this problem. Once you get into this problem, you have to be very careful because all of these problems are not the same. If you're talking about you put a punch in and that doesn't work out so well, that's fine. Just put in a larger anchor. So if you punch for a 4.75, put in a 6.5, just go straight to the big one and don't mess around. But you may want to put that anchor in, and before you start to repair, then maybe put your tacto set in to try to set around that anchor. So that way, as you're doing the rest of your surgery, maybe park those sutures somewhere, let it set. In this case, I would let the material set a little bit longer than normal, because now we're in a worst case scenario. I have gone in, the same partner that was actually busting my chops, the very first one of these I ever did, like the next day had one where he pulled out an anchor and there was just a huge crater. And he had created such a big crater that he thought he could just inject this stuff in, and he made it just a soupy mess. So you have to have some way of having some control and some containment, maybe even letting the material set a little longer than that 7 minutes before you even inject it. So that way you get a little bit of a head start on the setting process. I've never used, it's a great tip Dr. Ashraf says about turning up the pressure. I've never done that, but I think that's something that I might start looking at as well. It's all about pre-op planning, preventing this. Put in larger anchors, fill those defects in that, and then just go away from the area and inject that material. Again, you can see on those foam block studies that we did, it makes this cloud that goes through the cancellous bone. It does it even better in the native shoulder, because those are closed cells in the foam block studies. And if you do that, you'll get kind of a grit fill in between the threads of your anchors. In those cases, I would definitely use threaded suture anchors. I would not try to be cute with a tap-in knotless or all suture anchor in that situation.
Agreed. And another scenario that tacto set can be used for, if you think about it preoperatively, is around revision rotator cuffs. You go into revision rotator cuffs, you see these anchors. Anchors may, if it's biocomposite, you may have some cyst formation around the biocomposite screw, and you're going to put new anchors around this. So this is another scenario where using tacto set in the preoperative fashion, kind of planning for it, will speed up surgery and give you less headache intraoperatively. So again, I think thank you again for Dr. Baker, Greg DeConcilius. Thanks again for all your expertise. Thank you, Anika, for putting this event together. I hope we all were able to share some tips and pearls and techniques and reimbursement issues, or how to get reimbursed for tacto set in the case of a rotator cuff technique augmentation.